Pradhan, it was, you had been my father's friend, if I remember correctly, Dr. Saraj Gupta from Thakurpukur.
Yeah.
Dr. Praful Desai, my dad, they're all kind of contemporary. Anyway, I mean.
It's 7, sir. I think we are live now. So, Good evening, everyone. Welcome to the chapter 23 in this series of masterclasses brought to you by the Academic Council of IASO. The topic for today is laryngeal cancer. I invite IASO President Dr. Arnab Gupta to open this session. Thank you.
Yeah, good evening, everybody. It gives me immense pleasure to welcome you all. And I'm really glad, the way the PG Masterclasses have been conducted by the IASO Academic Council, which is obviously led by Dr. Subramanish Rao, ably assisted by Dr. Srajan Shukla, and then we have 4 eminent past presidents of IASO, Dr. Kiran Kothari, Dr. Rajaraman, Dr. L. Sarangi, and Dr. Arun Chaturvedi. Unfortunately, I think Dr. Rajaraman would not be able to join today. And Dr. Arun Chaturvedi has got poor network where he is at the moment, so he may be on and off when we get connected. And we have the privilege of having very eminent faculty like Dr. Sultan Pradhan from Mumbai, very eminent senior head and neck surgeon, doyen of head and neck surgery and teacher of teachers. And also along with him, we have Dr. Saji Thomas and Dr. Rohit Nair from New Delhi. And I believe that we have a presenter from Mumbai, is that right, for this examination?
Yeah, Dr. Kanav Kumar.
That's right, yes. So just before we start, I think it's also important that I announce that we are only a month away from NatCon, the National Conference of IASO, which is a very prestigious conference, a very popular event for our organization. So I would request everybody to kind of become a member of IASO if you're already not one, and then also register for this particular conference. We just text you the website for this IASO and also the NatCon conference. And I wish all the good luck for the examinee. And I'm sure we are going to have a wonderful discussion once again. And Dr. Pradhan's talk, I'm sure, is going to be the highlight for our PG Masterclasses once again. And thank you very much. We look forward to the session.
Thank you, sir. I invite Dr. Sharat Desai, our Honorary Secretary for IASO, to kindly introduce the examiners for today.
Dr. Pradhan, sir, doesn't really need any introduction. But still, as a protocol, I will have to introduce him. It's definitely a privilege for me. I mean, it's a great honor to introduce Dr. Pradhan, sir. He is a well-known alumni of Tata Memorial Hospital and Memorial Sloan Kettering Cancer Hospital of New York. He has published 3 books on the surgery of the larynx. He is known for the near-total laryngectomy, voice conservation surgery in cancer of the larynx and piriforms. He's pioneered a program to develop head and neck surgical oncology and the surgery of airway restoration with the ENT departments of many large hospitals. And he also has the Platinum Standard Award for the contribution in the field of healthcare in 2009. He's got the Lifetime Achievement Award for contribution in the field of head and neck oncology, from the International Foundation of the Head and Neck Oncology Services, IFNOS 2010. He's got the Dhanvantri Award from the state government of Maharashtra, awarded to him by the governor. And of late, he has been setting a 93-bed head and neck cancer institute of India, located in the south of Mumbai. After Dr. Pradhan, sir, we have got Dr. Rohit Nair, who is Dr. Shaji Thomas. He's the head of the Department of the Surgical Services in the Regional Cancer Center, Trivandrum. He's got a tremendous experience of 25 years. His main interests are in the head and neck cancer surgeries, oral, thyroid, salivary, and also reconstructive and the microvascular surgeries. So he has got about more than 50 national and international publications. Dr. Rohit Nair, alumni of my institute, the Gujarat Cancer and Research Institute. He's got an experience of more than 18 years. He has been working in Delhi, around Delhi for all these 18 years. And of late, he is in the Max Hospital, New Delhi. His main field of interest is in head and neck cancer and breast cancer. And these are our examiners for today. And Dr. Kanav Kumar is our student from, who is a student also of Dr. Sultan Fazal, sir.
Thank you, Sharad, sir. A few instructions for the session for our candidate. We expect you to give to-the-point answers. If, however, there's some question, the answer to which you don't know, there's no harm in mentioning it, as it saves us time and maintains the flow of this webinar. Examiners keep giving hints all the time. It's up to you to catch one. For our dear examiners, this is a mock clinical examination. So please feel free to interject and cross-examine the candidate throughout his history and clinical examination. However, in interest of online viewers, we request you to give the expected answers to the questions that remain unanswered or have been incorrectly answered. The time for the case discussion would be 60 minutes. I'll be reminding our examiners at 30 minutes and at the end of the case discussion. Without any further wait, I request Dr. Kanav Kumar, who's the candidate who's going to present today, to kindly load up his screen and commence his presentation. I request the examiners to take the proceedings forward. Thank you.
Thank you, Dr. Sijan.
Good evening.
Good evening, Kanav.
Good evening.
Good evening, Dr. Kanav.
Sir, I'll be presenting a case of a 54-year-old gentleman who presented to us in the OPD. He was a shopkeeper by occupation, resident of Srinagar. He came to us with chief complaints of hoarseness, which he had since the last 4 months. He was apparently all right 4 months back when he developed hoarseness, which has gradually progressed, and it had progressed to the present state when he presented to us. He did not have any history of difficulty in swallowing, no history of swelling in the anterior or lateral aspect of the neck, no history of any foreign body sensation in the throat, or no history of any referred pain to the ear. He did not give any history of coughing while having liquids, no history of noisy breathing, no history of cough, hemoptysis, or any difficulty in breathing, and there was no history of loss of weight or any loss of appetite. In his past history, he did not have any history of hypertension, diabetes, ischemic heart disease, tuberculosis, or COPD. There was no history of any surgery in the past. He did not have any addictions. Sleep, appetite, and bowel bladder habits were all normal. There was also no significant family history. Can I proceed with the examination, sir?
There was no. The only symptom that is hoarseness of voice change alone.
Yes, sir.
It doesn't have any other pain or no other aspiration, nothing. Okay.
No symptom.
What do you think? What does it point to, Kanav? What are the likely possibilities when somebody comes with hoarseness for 4 months?
Sir,
is it persistent hoarseness, or does it open up sometimes and again it becomes hoarse, or is it persistent hoarseness?
So it was persistent hoarseness that gradually worsened over this 4-month period.
Okay.
What does it indicate?
So this, yes, sir. This would indicate most likely a pathology that is arising in the larynx, most likely the glottis, and more likely to be unlikely to be an inflammatory etiology, more likely to be maybe a malignant etiology because it's worsening and it's since 4 months.
So of the 3 subsides of larynx, most probably it could be from the glottic origin.
Yes, sir.
Okay.
Can it be from outside of larynx?
Sir, it can be. Many times a patient with a thyroid malignancy can also present with hoarseness of voice. That may be the presenting symptom. And also, it may also be a advanced lung cancer, and he may present with hoarseness of voice due to involvement of the laryngeal nerve by paratracheal nodes.
It's not rare. It's not rare. So, lung cancer causing the recurrent laryngeal nerve palsy is not a rare thing.
Yes.
Can it be non-neoplastic totally? Can there be something that will cause hoarseness without any known pathology in the larynx or any neoplastic etiology?
So, kind of,
yes, sir.
Patient doesn't have any habits, smoking or chewing, nothing, no tobacco habits.
No, sir.
Okay. So, can you think anything other than a malignant process? Anything?
There could also be idiopathic vocal cord paralysis or a vocal cord polyp, which can cause hoarseness.
Any neurological cause?
Yes, sir. There can also be neurological causes like myasthenia gravis or any neuron disease that may cause it.
Myasthenia gravis causes hoarseness or causes voice fatigue at the end of the day?
Sir, which is seen more in the evening.
What is the other neurological condition that causes hoarseness? Idiopathic nerve palsy?
Yes, sir.
Have you heard of idiopathic recurrent laryngeal nerve palsy?
Yes, sir. Idiopathic nerve palsy.
Okay. Since the gentleman has no habits, one has to think of these other.
So, all the options has to be kept in mind because the only symptom is the hoarseness of voice, and there is no habits also.
Okay,
and okay, carry on.
Carry on, Karna.
Yes, sir. On general examination, sir, the patient was conscious, cooperative, and well oriented to time, place, and person. He had an ECOG performance status of 0 with a BMI of 22.7 kg per meter square. He was afebrile and his vitals were stable, 68 pulse of 68 beats per minute and a blood pressure of 124/70 millimeters of mercury. He did not have any pallor, icterus, cyanosis, clubbing, pedal edema, or generalized lymphadenopathy. On local examination, on inspection, his mouth opening was 3.5 centimeters. There were no loose teeth. No submucous fibrosis was seen. The oral cavity appeared normal, and he did not have any difficulty in extension of the neck. On palpation, there was no widening of the thyroid cartilage that was palpable. No other swelling that was palpable in the region of the thyroid. No palpable cervical lymph nodes. Laryngeal crepitus was present, and bilateral carotid pulsations were well palpable.
So in the general examination, you specifically told there is no restriction of neck extension. Why? What was in your mind?
Sir, in an advanced laryngeal malignancy that is involving the prevertebral fascia, the patient will complain of difficulty of extension of the neck. We had then done a 70-degree Hopkins examination in the OPD.
How will you further proceed?
Sir, we have done a 70-degree Hopkins examination.
Okay.
Let's see that.
We can see the growth that is seen on the right vocal cord reaching the anterior commissure. The movement of the right vocal cord is slightly impaired as compared to the left, but both arytenoids are freely mobile.
Is this with the rigid? Is this with the rigid scope, Kanna?
Yes, sir, rigid scope.
Kind of you in the outpatient clinic, you first do a rigid scopy or you do a mirror examination first, or then go for a rigid? Hopkinscopy?
Sorry,
usually?
sir?
Will you do a mirror examination in first?
We do the rigid scopy directly, sir.
Rigid scope, okay.
Does anyone do a mirror examination now?
Those who come from maybe in the ENT, those who come from the ENT background, they first, maybe in some centers they do, but most of the centers they do either in a flexible office endoscope or a rigid scopy.
So which is better, Karnav? Is the flexible scopy better or this is better?
So the flexible scopy is better, sir.
So what additional information you get from?
So we start by examining the nasopharynx into the oropharynx and then the glottis.
Okay. So what about the visibility of?
It's a matter of personal preference, Karnav.
Okay.
Matter of preference. I don't think there is much to choose, but there is greater and greater tendency today in institutions to go more for the flexible scopy. Greater and greater tendency.
Yeah, because you have an option of taking biopsy as well simultaneously with these flexible scopes. So when you put the scope in, if you find lesion, you can take biopsy simultaneously in the same sitting. So your job is done in one sitting itself. So that is the advantage of a flexible scope. Otherwise, as far as viewing is concerned, for laryngeal view, you have a Hopkins, which give you a good view of the lesions. So office procedures can be done straight away with them.
Okay.
So, kind of, what all things you look into when you do a 70-degree or a rigid scopy? What all things you do? Observe. What all things you look for?
So we start by visualizing the base tongue, valleculi, supraglottis. We see the epiglottis, and then we move to the we see the glottis, the movement of both cords, movement of the arytenoids, both pyriform fossils.
Okay, then airway assessment.
Yes, sir. Depending on the location of the tumor, whether it is obstructing the airway.
Airway, the extent, whether it's extending, transglottic lesion or extension of the extent of the disease also.
Okay. Which areas you cannot see on the scope? Are there any areas which are not visible on rigid or a flexible scopy?
So the apex of the pyriform is difficult to see.
What?
Yes, sir.
What else? Apex of pyriform and?
Post-cricoid, sir.
Post-cricoid, yeah. Okay. So many times post-cricoid areas are not visible even with the flexible scope or with the rigid scopes. So for whenever lesions are there in the post-cricoids, you have to do a rigid laryngoscopy for them.
Unless there's an obvious growth in the post-cricoid, then you can see it.
Yeah.
So what is your diagnosis now, Karnav? Up till now, whatever you've done, what is your diagnosis?
Sir, my diagnosis would be a carcinoma of the glottis, and I would state the disease as a clinically T2N0M0 disease, sir.
Because you think it is extending into the supraglottis?
Sir, because the cord mobility, I feel that the mobility of the right cord is impaired compared to the left. That is why I would keep it as a T2 disease.
Anteriorly. It's a little difficult to appreciate that. Very often it is the eyes of the beholder.
Okay. So why there is what could be the reason for a restriction of the vocal cord mobility?
Sir, vocal cord mobility can be restricted if there is involvement of the thyroarytenoid muscle that can cause, or sometimes the bulk of the tumor may also cause restricted mobility.
Okay, so what is the next thing you would like to do now?
Sir, I would like to proceed with imaging that will help us stage the disease, locoregionally stage the disease.
Okay. Would you like to do a biopsy first? Would you like to do the imaging first?
So imaging first.
Why?
So non-invasive procedure first prior to invasive, and sometimes biopsy may also affect the imaging cause artifact.
Okay.
I would like. Yes.
So what is your imaging of choice?
Very unlikely that a biopsy is going to change the imaging. But yes, if you have done the imaging, then when you are doing the direct laryngoscopy, you will try and look at those areas more carefully, what the imaging suspects. I don't think that a punch biopsy is going to change the imaging unless you're doing PET scan. Then of course it will show an inflammatory response there. Okay, so you have done the imaging?
Yes, sir. We've done a CCT of the neck and thorax, contrast and CT.
Okay.
You have to read it for us, huh, Kanna?
Yes, sir. Here, sir, we can see the epiglottis that has come into view.
Yes.
These are the axial images. Here we can see the valleculae, both valleculae, the median and lateral glossoepiglottic fold. That appears okay. This is the hyoid bone. These are the AE folds, the area epiglottic folds. Now we can see the cords. There appears to be a thickening over the right vocal cord that seems to be reaching and probably crossing the anterior commissure. And the paraglottic space seems to be involved on this side, sir.
Is there any plane seen between the paraglottic and the inner border of the thyroid cartilage?
Sir, it seems to be involved on the bone window, sir. We can also see that there seems to be some.
For a lesion in the vocal cord that is extending to the anterior commissure, what thing you specifically look in the CT?
Sir, we look for involvement of the thyroid cartilage, sir.
Okay, sir.
Anterior commissure regions are known to involve in the cartilage.
There could be subtle, small erosion of the.
In this scan, so there seems to be some irregularity of the inner perichondrium.
Thyroid.
Go on lower down. You want to see lower down?
Yes, we'll look for any support.
Okay.
It seems okay, so the support seems okay.
There is a. So CT-wise, it's a purely glottic lesion.
Yes, sir. On the coronal cuts, there seems to be some involvement of the ventricle and the false chords as well.
Have you ordered CT scan of head and neck and thorax?
Sir, this would, the thorax mainly to look for any metastasis, and which is although less likely in a glottic tumor, but there is also a tendency for second primaries in these patients. Glottic.
He is non-smoker, he is non-tobacco chewer.
Yes, sir.
So do you think that these patients can have a metastasis with a high possibility of metastasis or somewhere else on a second primary, which is more common in smokers or tobacco chewers?
Yes, sir. More common in a smoker to have a second primary. And glottic cancers are unlikely to, early glottic cancers are unlikely to have lung metastasis.
Nice. Okay. What is the chance of nodal metastasis for this patient?
Sir, in this patient, because there is erosion of the inner perichondrium, he would be, and the paraglottis is involved, it would be a T3 disease, sir. In a glottic T3 disease, the chance of nodal metastasis would be about 15%, sir.
And you told there is some supraglottic extension is there, ventricular bands.
Yes, sir. Supraglottic tumors have a higher tendency of nodal metastasis, bilateral nodal metastasis.
So it is good that you've ordered CT thorax also simultaneously along with the neck. We were just checking whether you know why you are ordering.
What about an MRI? Would an MRI have been better?
Sir, CT is our investigation of choice. MRI is more like a problem-solving tool that is maybe used in cases where we are suspecting early cartilage erosion or better delineation of the spaces like the paraglottic space if it is required. But mainly CT is our first choice.
Good.
Imaging of choice is contrast enhanced CT.
Yes.
Okay.
With very fine cuts.
Yes.
So, what all additional information you got from the CT than your endoscopic examination?
Sir, the CT also showed us that the paraglottis is involved and there is erosion of the inner perichondrium of the thyroid cartilage.
So it has helped to change your staging?
Yes, sir. It will become a T3 disease, sir. There are no gross lymphadenopathies, would be a T3M0 disease.
What is the next step now, Karna?
I would like to do a direct laryngoscopy and a biopsy, sir, for tissue diagnosis and to map the lesion to corroborate the findings of imaging.
Okay. You want to show us the direct laryngoscopy or it's just...
Yes, sir.
Have you done a video laryngoscopy?
Yes, sir.
Why do you need to do video laryngoscopy? You've already done the 70-degree Hopkins. Why do you want to do a video laryngoscopy?
Sir, depending on the different scopes that we have, we can assess like a 0-degree scope is will help us visualize the glottic lesions. 70-degree scope may help us for the any extension, subglottic extension and ventricular extension.
Anterior commissure.
Anterior commissure.
Mostly it is the anterior commissure that you will see with the 30-degree or the 70-degree. And video laryngoscopy is certainly far superior to the tube laryngoscopes. But you need tube laryngoscopy to take a biopsy, isn't it?
Yes, sir.
So you've done both?
Yes.
You did it under anesthesia or?
Yes, under anesthesia.
GA?
Yes.
So let's see that.
This shows a growth that is seen over the right vocal cord, and it seems to be involving the ventricle on the right hand side. The false cord does not appear involved on this scope.
It's rigid.
Yes, so the paraglottis seems to be does not seem to be supple.
I see that you've done a suspension laryngoscopy, Kanna.
Yes, sir.
A microlaryngoscopy.
Yes, sir.
Why have you done that?
So suspension laryngoscopy is usually required in case we are planning a laser excision.
So you wanted to assess for that?
Yes, sir.
Now tell me, what all things are you going to assess on suspension microlaryngoscopy to judge whether or not it is resectable with transoral laser dissections?
So the location of the tumor, whether it's a purely glottic lesion, any extension into the supraglottis or any subglottic extension, involvement of the anterior commissure. So also firstly, the main, we need good exposure. Exposure is what is the most important for if you are planning laser microsurgery.
Yes.
And paraglottis involvement, anterior commissure involvement, subglottic involvement. This will help us decide whether we want to proceed with laser excision or we would want some other form of treatment.
So involvement of the opposite cord, is that important?
Yes, sir. If it's involving anterior commissure and crossing over to the opposite side.
So what do you think, sir?
Why is that important to know the extent of anterior opposite cord involvement?
Sir, usually if the tumor is extending onto the anterior commissure and crossing over to the opposite side, usually it is these cases don't do very well with the laser. They are usually radiation therapy is usually preferred in such cases. And in case we are using the laser, then we may have to place a keel to prevent web formation later on.
So, do you think this is an ideal case for a laser excision from your findings?
No, sir, it is not an ideal case.
Okay. So, what is the specific problem with the anterior commissure lesions when you plan for a laser excision?
Sir, there is a higher tendency of cartilage involved, thyroid cartilage involvement with the anterior commissure. That is why.
Another thing is the exposure itself is difficult. Proper exposure, microlaryngeal exposure is difficult. Then difficult to get a deeper margin, completely negative deeper margin. So another thing is there's a high chance for a post-op adhesions and synecdoche formation, and the voice quality won't be good. Okay. So you took a biopsy?
Yes, sir.
Okay.
One of the things, Kanna, one of the things that you want to see is the extent of opposite cord involvement. For certain procedures of open partial laryngectomy, it is very important to know that.
Yes.
I'm not saying it for this particular case, but whenever you are doing a direct laryngoscopy or a macrolaryngoscopy, you want to see the extent of the lesion. You want to see whether the anterior commissure is involved, and you want to also see whether or not the opposite cord is involved and how much. So that if you have to resect, for example, if you did a near total laryngectomy, we don't nowadays do that often, you would not be able to do it in a case like this. Because your resection would come almost, if the front portion is involved, your resection will come almost here. or even here, and you will not have enough to form the voice tube. So you mentioned everything very well, but you have to mention also the extent of contralateral node involvement. Good. So you took a biopsy?
Yes, a biopsy was taken. That showed individual squamous carcinoma.
Okay. Now what? So when is your final staging is T3N0?
Yes, sir, T3N0.
And invasive squamous CA. How will you treat this?
Sir, I would like to discuss the options with the patient, sir.
Yes.
What are options?
So the one option would be that he received definitive chemoradiation.
Yes.
So,
and what is the other option?
Other option is that he an open partial laryngectomy is another option. So probably a supracricoid partial laryngectomy.
Okay.
So
and the third option?
These options with the patient.
So what is your choice and how are you going to explain to the patient those choices?
Sir, my choice would be definitive chemoradiation would be my choice for the for this.
Concurrent?
Yes, sir, concurrent.
Concurrent chemotherapy?
Yes, sir.
Okay. So what gives what is the chance of a cure rate for this patient with concurrent chemotherapy?
Sir.
T3.
Yes, sir. Sir, according to the RTOG 9111 trial, it showed that patients treated with concurrent chemo radiation, 88% of those patients had larynx preservation.
Larynx preservation, okay. So of the various non-surgical options, chemotherapy gives the best outcome, larynx preservation rate.
Yes, sir.
Kanav, why will you not do the surgery? You just you're doing a surgical option is one of the options for treating them. So why did you choose CTRT? Why not surgery?
So surgery, a partial laryngectomy like a supracricoid partial laryngectomy would have inferior voice quality as compared to when he would be treated with chemoradiation. And also he would have the post-operative course post supracricoid laryngectomy is very stormy due to the high chance of aspiration post-operatively.
Yes.
So that is why I would prefer chemoradiation as my form of treatment.
So before planning surgery, you have to check for the pulmonary function test for your patient. So any patients who is going for a partial laryngectomy, so pulmonary function tests are very important. So if they have a good pulmonary function test, because they tend to have aspirations in post-op periods. So a good pulmonary function is a must before you plan any partial laryngectomy procedures. Secondly, what about the control rate? Are the surgical control as well as the radiation same or is it different?
So it's been found that the control rate post-surgery is actually better as compared to chemoradiation. Although there is no head-to-head analysis.
Is there any randomized or head-to-head comparison?
So there is no comparison.
Okay.
Yes. So looking at the morbidity of the procedure and the long recovery phase, and secondly, it's a T3 tumors. So you need to check for your margins. You need to check for the nodal state. Well, you said 15%, so you'll be doing a prophylactic node dissections as well for this patient. This is going into a supraglottis as well. So you will do bilateral neck dissection. You will not do neck dissection.
Sir, I would at least do the ipsilateral side, sir, the same side.
But this is crossing midline, is going on to the other side as well.
Yes, sir. In a supraglottic tumor, sir, it is recommended that bilateral level 2 to 4 are cleared, sir.
But radiologically, it's N0.
Yes, sir. Radiologically, it's N0.
But still, if you are planning surgery, do bilateral neck.
Yes, sir.
So how will you rate the quality of life, this chemo RT versus open conservative procedures
So
for this patient?
Would be better with chemo radiation, sir, as compared to open partial laryngectomy.
So with the advent of the newer machines that we are having for radiation right now with IMRT and IGRT techniques, the complication rates are much lower now compared to when it was 15 years back or 10 years back. So if you see the previous data of the previous studies which has been done, nowadays the complication rates are much lesser and the quality of voice is also good. And even aspiration and swallowing is not that bad after radiation. So that's the reason why the larynx preservation surgeries have gone on a back foot now. We hardly do partial laryngectomies, open partial laryngectomies now, except for early lesions. So when will you do surgeries in case of a laryngeal cancers?
Sir,
and what type of surgeries normally you do?
Sir, partial laryngectomy, sir?
Or even any other procedure, other type of surgeries you may opt for. If suppose it's a lesser stage tumor, it's a T1, T2 tumors. So this is a T3 tumors with a paraglottic space involvement. If there is no paraglottic space involvement, no cartilage involvement, is there any other surgical option which is superior or almost equivalent to radiation?
So vertical partial laryngectomy can be done. That is usually done if it is a verrucous carcinoma where we want to avoid radiation, or if the patient has a history of radiation to the same region previously, or in a very young patient if we want to avoid giving radiation to this patient.
What patients do you choose for a open conservative procedures?
So mainly T2 tumors, T2 glottic tumors that may be verrucous, or in a young male, partial laryngectomy can be done.
And now, if this man was very young, very healthy, and if you say that the results of a supracricoid partial laryngectomy are superior to those with chemoradiation, would you offer him a supracricoid partial laryngectomy? You know, cure rates of upwards of 90%, 95% are being offered with that. Would you do that in preference to giving chemoradiation for such a man?
Sir, it would also depend on his voice demands, sir. Because post supracricoid laryngectomy, voice quality is inferior to chemoradiation. So that would be one factor that we would have to take into consideration. And then we would offer both options to him with explaining to him that post chemoradiation he may require in about 15% cases there is a recurrence of disease and they do end up with a laryngectomy.
And I think it is more than 15%. I don't think that the chemoradiation is offering 88% cure rate. Shaji? Is the voice preservation rate 88% with chemoradiation?
It's 84 or something. Of the non-surgical options,
to the best of my knowledge, it is between 75, 78%. It's not
something around 80% usually.
It's a sizable number will fail. And not all of them have perfect voice. So if there's a young man who says, as long as I can talk, if my disease remains under control, and if I can avoid radiation, I'd like to have that.
Yes,
would you go for it? Kanna?
Yes, sir. Yes.
And what kind of reconstruction will you do after a supracricoid laryngectomy?
Sir, a cricohyodoepiglottopexy.
Yeah. And would you give them postoperative radiation?
No, sir. In such a patient, grossly N0 and
no.
You have to properly choose the patient. who will do functionally well with the conservation procedures. What are the ideal patients for a transoral laser surgery in glottic cancers?
Sir, a T1 mid-cord lesion is the ideal one for, with adequate exposure, is the ideal one for transoral laser resection.
So how do you, after you've done chemo radiation with this gentleman,
yes, sir.
He recurs. Do you have any voice conservation option left after this?
So it's this most patients, and it's also the safest to do a total laryngectomy in a salvage setting.
And what are the problems with that?
In a salvage setting, so there is high chance of a fistula formation, pharyngocutaneous fistula formation.
So do you take any precautions for that?
Sir, if the radiation effects are very severe, we can do a preoperative, we can do a percutaneous gastrostomy. A peg insertion can be done.
No, intraoperatively, when you do a total laryngectomy for a primary surgery and a salvage surgery, what all additional precautions you have to take in a salvage surgery?
So the closure, yes, sir.
Okay.
Closure is important, and if required, for a good vascularized tissue can be used for augmentation of the pharynx.
The pharyngeal fistula rate is high in the salvage setting, so you should have a well vascularized mucosa, tension-free closure, bringing in new tissues whenever it's needed, patch pharyngeoplasty.
So what is the best vascularized tissue that you can get to cover the pharyngeal closure?
So a free radial forearm artery flap or anterolateral thigh flap can be used.
Something local and pediculed?
Sir, PMMC can be used, pectoralis major myocutaneous flap.
Any other regional flap from the neck itself? Anything?
Supraclavicular and deltoid.
Okay. Supraclavicular flap is in the immediate vicinity. You can augment the vascularity, the pharyngeal closure with the deepithelialized flap.
So I think that is important. Not in all cases do you need that, but when the surgeon is doing the laryngectomy in a post-chemo RAD patient, he will have to use his judgment, like Dr. Shahji mentioned, debride all the non-supported mucosa. The mucosa has to be properly supported with the pharyngeal constrictor muscle. The excess mucosa should be snipped off. And when there is no tension and you close it, but you're still not very happy with the vascularity of the tissues, then you can cover it with a pectoral myofascial flap. If the mucosa is deficient, then the pectoral myocutaneous flap to augment the pharynx. But if the pharynx is adequate, then you only need a pectoral myofascial flap to cover the pharyngeal suture line. You agree with that, Kanna?
Yes, sir.
Shaji?
Yes, definitely.
Rohit?
Yes, sir.
Any other questions for Kanna? How will you rehabilitate his speech, Kanna? Tell us that. How will you rehabilitate his speech?
Prior to a total laryngectomy, I would like him to have some to visit the speech therapist, where he'll be told about the options of speech rehabilitation, which include either a tracheoesophageal prosthesis, either using an electrolarynx or esophageal speech. and depending on all options can be offered to him. And if required, a prosthesis may be inserted at the time of surgery.
So this patient, after doing a salvage surgery, will you plan for a primary TEP or a secondary TEP?
So better to not do it at the same sitting, wait and do it later once all the healing has occurred.
Okay.
So when do you prefer primary TEP, Kannav?
Sir, in a upfront case, not post radiation.
Yes.
Primary surgery, primary total laryngectomy.
What are the different ways of treating laryngeal cancers? So apart from lasers, is there anything robotic surgery which is nowadays pretty commonly happening in major centers? Any role of robotic surgery in laryngeal cancer?
Yes, the transoral robotic surgery is also an option. It is usually preferred for supraglottic tumors. And for glottic tumors, there isn't much of an advantage over laser microsurgery, but there is definitely a role in supraglottic cancers.
So what is the difference between a robotic surgery and a laser surgery?
So the degree of freedom, the movement is better, 7 degrees of freedom with the robotic surgeries.
And the visibility also, maybe.
Yes.
You have a 3D magnified view that gives you the exact picture of the larynx, their larynx.
And you said that laser is superior than robotic. So in which way laser is superior to robotic?
Sir, it is...
Why do you think so?
It is not superior, it is equivalent. There is no advantage of...
You said for glottic tumor, you prefer to use lasers rather than robotic. So any particular reason for that?
No, sir.
You have a better view, you have a better maneuverability with the robot. So what is the advantage of lasers over and above robotic surgery? So what do you use in robotic surgery? You're using an electric cautery, correct? Yes. The same cautery which you are using for open surgeries, you're using with the robot, but with the magnified view, and you have a precision, you have a small point through which you can excise and remove the tissues under vision. That's what, and access. So robot gives you a good access inside, whereby going through the laryngoscopes, the vision gets altered, so and the movement becomes restricted. So that's how robot helps you in doing the supraglottic surgeries. But what is the advantage of, what is the difference between a laser and a robot? How does laser work? We use lasers in oropharyngeal surgeries also, we use robot also. And lasers been in use before robot came in. And what is the mechanism of action? How does laser work and how does the robot work? So how does laser work? When it cuts, what does it do? Which lasers you are using?
So CO2 lasers.
So what is the advantage of CO2 laser? How does CO2 laser work?
Also gives hemostasis.
Now, how does it work? So what is the basics of the lasers which we use it? The depth, the precision, the sealant, how does it work? So what is the advantage of laser? Why not to use electric cautery straight away? Why we are using lasers?
With the electric cautery, so lateral spread is more. Here it is more precise with the laser.
Then what else? That is number one. Number two, advantage of lasers.
What about the healing? Scar formation.
Scar formation, yes.
What about the ability to couple the laser to the operating microscope? That is the greatest advantage, Kannav.
Yes.
That is the greatest advantage.
Manipulate it.
With cautery, you cannot reach the
microscope.
larynx. the fact that you have magnification of the operating microscope and you can couple the laser to the operating microscope and you have the joystick for remote control and operating the beam, that is the greatest advantage of the carbon dioxide laser. So remember that in the exam. Yeah?
And maybe the postoperative inflammation, edema formation will be less in a laser. So how will you follow up this patient after chemoradiotherapy?
Sir, after about after 12 weeks, I would like to do a PET CT scan, sir. And yes.
So what do you see on PET CT scan?
Is it a standard?
Sir, a PET scan is good to differentiate between fibrous tissue and disease. So any significant uptake. I would first do a clinical examination and if required, then a PET CT scan at 12 weeks.
Okay.
Otherwise, every 12 weeks, you don't go on doing PET scans. Yeah?
Yes.
I think this is important.
Yes.
You do a clinical examination. Generally, if the patient is fine and if he has no symptoms, I don't think it is advantageous to keep doing the
CT.
Yeah. If you have to do a total laryngectomy on him for recurrence, Kanna,
yes, sir.
What kind of total laryngectomy do you do on this patient as compared to the one where you do a total laryngectomy per primum?
So it will be a narrow field laryngectomy, sir.
Narrow field laryngectomy. Why?
Sir, because the neck would have already been irradiated. Bilateral neck would have been.
And would you take any precautions against this?
Sir, minimal raising of skin flaps and closure. We would try to have tension-free closure.
That we have talked about. What I'm trying to ask you, Kanna, is you said you will do a narrow field total laryngectomy. That means you will not address the level 2, 3, 4 lymph nodes.
Yes, sir.
Which you would if you were doing a laryngectomy per primer. You can be very sure that there will be no lymph node beds.
Certain studies do show that there is a chance, but it's a very small possibility, sir.
But will you take some precautions before you finalize a narrow field versus a wide field total laryngectomy? Some imaging you'll do?
Yes, sir. PET scan can be done, although PET is not very good for occult matters.
An ultrasound can be done.
For assessing neck, PET alone, PET is not
a very good investigation for lymph nodes.
Ultrasound can be done.
What I want to remember is that narrow field laryngectomy is the correct answer. But prior to finalizing that, it is always better to get a sonography done to see if any of the lymph node is suspicious. And if it is, then your sonologist can do a fine needle aspiration.
Get it.
What you have to remember, Kanna, is the mind tells you that I must play safe and do a narrow field total laryngectomy. If the neck node does appear in future, the chance of that is very, very small. If it does appear, then I will do a neck dissection. So what you need to know is that neck dissection is generally not possible. After doing a laryngectomy, if after a few months it develops a node in the neck, most of the time you'll find that a salvage neck dissection is not possible. So I don't disagree with you when you say I will do a narrow field laryngectomy. I would also do that. But I would do a sonography to see that the lymph nodes are not involved and then do the wide field, narrow field total laryngectomy. It is not easy to salvage a neck with metastatic neck nodes after a total laryngectomy in a previously chemo-radiated patient. You have to remember that. Saji, you agree with me?
Yes, sir.
Definitely.
Rohit?
Definitely, sir.
Yeah, I think it's important to know that.
Yeah.
What about the thyroid lobes? Will you preserve?
Sir, ipsilateral.
Salvage setting.
Sir, ipsilateral hemithyroidectomy, I would do that.
What about in the post-op period, what else will you keep in mind for these patients who have had chemoradiation?
So thyroid function tests also to be checked.
Very important.
Okay, very good. Yes.
Very important.
Is there a hypocalcemia possibility?
Yes, sir, there is a possibility of hypocalcemia in these patients.
So you have to look for that as well. So calcium and thyroid, both are important. So
thyroid function test.
So what is the follow-up protocol for these patients? What in follow-up, what protocol you follow? Which test to be done? Patient comes, and when do you call them for follow-up? When is the first follow-up and when is the subsequent follow-up? What do you do in first follow-up? What do you do in subsequent follow-ups?
Sir, we first see the patient at 3 months, sir. We do a clinical examination.
So what do you do in clinical examination?
Sir, an examination of the neck and the indirect Hopkins laryngoscopy is done. Sir.
Okay.
And we assess his symptoms, whether there is any, whether there is improvement post-treatment or worsening of the hoarseness. And
any labs that you do? So give me an idea, what in first visit, what will you order? You've examined patient, do you order some test?
So usually a thyroid function test is recommended to be done at 6 months post completion of
okay, so in first visit, what you do in subsequent visit. So when are you going to call these patients? Every 3 months in the first year?
Yes, sir.
And then second year?
Then we can increase it to 4 or 6 months. Sir.
4 months in the second year, and then?
Then 6 monthly, sir.
6 monthly from third year onwards, correct?
Yes,
so every visit, what do you do? So you do a clinical examination, patient is asymptomatic. So do a clinical examination, you do a thyroid function test from the second visit onward, not in the first visit. So first visit, you are doing only clinical examination, correct?
Yes, sir.
Second visit, you check for thyroid and the clinical examination. That's all?
Yes, and sir, if a narrow field laryngectomy is done, you can follow up the patient with an ultrasound of the neck to look for any nodal involvement.
So, will you do a CT scan or an MRI for this patient?
Usually, sir, a PET CT scan is recommended for assessment post-treatment. That is a better idea compared to a CT or MRI.
When do you do a PET CT scan for these patients? In all patients, you do PET CT scan, or in certain subset of patients, you do PET CT scan? You do PET CT scan, or you will like to do an MRI or a CT scan?
Sir, in patients who are, if they report any worsening of symptoms or there is any suspicion of on clinical examination, that's when I would do an imaging.
So what imaging? Will you do an MRI, a CT, or a PET straight away? Why will you do PET scan?
A PET scan can help differentiate fibrous tissue from disease, which is not very clearly, which cannot be differentiated very well on a CT or an MRI. And
but if you see lesion, you can do a biopsy from there. Why you want to do PET CT? A fibrous lesion can be differentiated into malignancy by biopsy, which will give you 100% diagnosis.
Yes,
PET is still not confirmatory.
Yes,
you still have to do a biopsy. Why you want to do a PET which is 30,000 or 25,000 in a patient?
It's also one, it's a single imaging will give us an idea on any distant metastasis and.
But you can see the lesion on laryngoscopy. You do biopsy, it is negative.
Yes, sir.
Will you do PET in all patients?
We would prefer a PET over a CT. So not required for all patients, but if I had to choose one imaging, it would be a PET CT. So
always you will do PET CT?
No, sir.
Then, is there any role of MRI or a CT scan in follow-up?
In the post-operative follow-up, on examination, you see there is edema, gross edema. What are the possibilities?
Sir, there is normally there is edema seen post radiation. So that is not something that is abnormal. So that
but you have to differentiate between a submucosal disease process versus a post-radiation edema. If the persistent edema is there,
yes, that would help. The PET CT would then help with the uptake. Would then give us an idea on.
What about the MRI?
MRI can also help, sir.
So one investigation costs 7,000 rupees, another investigation costs 25,000 rupees. One is available in your city. Suppose you are not in Mumbai, you are in Gorakhpur. There is no PET CT facility. So what will be your diagnosis? What will be the investigation of choice for you? Will you do an MRI when you are suspecting a disease in the presence of edema?
Yes, sir. An MRI can be done then.
So how do you differentiate between a post-radiation necrosis and a disease? PET will show uptake in both. Necrosis is also picked up on PET. So how do you differentiate that?
So the by the SUV max, there would be a higher uptake in disease. The uptake would be higher, sir, in disease. The SUV max.
It is still not sure. Both will show an increased uptake. SU will be high in both the cases. Even the necrosis will show high uptake on PET.
Biopsy would be required then, sir.
Yes. So biopsy, and that too deeper biopsies. So you have to have a coring biopsies. Deep coring biopsies needs to be done in post-radiated patients. So it becomes many times very difficult to convince patient that they've got a disease. You take a biopsy, it is negative, but PET is showing an uptake. So differentiating between them becomes even more difficult. Patient will keep coming with the symptoms of hoarseness of voice, difficulty in swallowing, edema. Then you have to judge, and it is called deep coring biopsies, where you have to go deep submucosally and take biopsies from there to diagnose a recurrent disease. Okay. So it's very important that you should not order PET loosely to all patients who are coming for follow-up. PETs are reserved. It's an expensive test. Most important, clinical examination, any suspicion, take biopsy from there. This will prove your diagnosis. You don't need to go for PET to check for an uptake and then you do biopsy. Okay. So if you're sitting in Gorakhpur, you don't have PET facility. So you must develop your practice, which is first and confirmatory and easily done. Go ahead and do that rather than ordering a radiological investigations. Okay. Any other questions anybody have? Please. Thank you, Kanav. You've done a wonderful job. I think...
so, Kanav, from the general surgical background, you did extremely well. Yes. All the points, clinical examination, everything you have brought out. Well done.
Thank you, sir.
Very well done. So we just wanted to insist on the clinical aspects. It's very, very important to assess patient clinically. Most of the informations you will get through a good clinical examination. So your imaging only tries to corroborate your clinical findings. So you should be more sure of your clinical assessments. Thank you. You've done an excellent job, Kanav. Thank you.
Okay, Kanav.
Thank you, dear examiners. Thank you, Dr. Kanav. Before we move on to talk by Dr. Sultan Pradhan, sir, we would like to share a small video regarding the upcoming NatCon. I'll share the video from my side, and then I'll invite Dr. Dutta Acharya, sir, to please give his comments. Thank you.
This is our video जो virtual था ना, वो रिलीज हो रहा है आज मास्टर क्लास. ले लो यार, नरेश भाई. So this is Dr. Rudra, Dr. Harith, and Dr. Chintamani from Delhi, organizing committee of the NatCon. So we welcome everybody. Please register and send your abstracts, and we will be having a mega virtual NatCon IASO 2021 this year.
Dr. Harith Chaturvedi wants to say a few words. Dr. Harith Chaturvedi?
Yeah. So Dr. Dev has worked very hard with the team to create a wonderful scientific program. We are already confirmed 20 international faculty. It's an organ-based, from head, neck, breast, GI, gynae, everything, all organ-based programs. And so everybody who participates will benefit. There are a lot of competitions, more than 150 awards on quizzes, and there's a competition on case-based presentation also from institutions. And we are expecting 1,500 plus abstracts and posters. So this is going to be a really watershed NatCon, and we are all very excited for next 2 months. I think we'll be having a very exciting time to bring it all together. So all students, all faculty, every surgical oncologist is expected to be there, and all those who want to be a surgical oncologist have to be there to really get the best out of this. Dr. Chintamani, I will request him to say a few words.
I think thank you very much. A very good evening to all of you. I can see some very familiar faces. Looking forward to a great event. I'm sure you're going to have a great time. And in this scenario, having a hybrid meeting, scientific program has been created, and the way we are looking at it, we're going to cover up for the younger people especially. So as Dr. Harith mentioned, the budding surgical oncologists, just not the established ones, would be relishing it tremendously. So looking forward and welcome you all to this mega event. We need your support and cooperation in every activity that we do. Thank you very much.
Thank you.
Thank you so much, sir.
Thank you.
We move on now to the expert talk with Dr. Sudhar Pradhan, sir. So you can share your screen and we are all yours, sir.
First of all, thank you very much for getting me back into the academics, temporarily at least. I've been asked to speak on contemporary management and controversies in cancer of the larynx. And when one talks about contemporary management in cancer of the larynx, 3 developments immediately come to mind. The first is transoral laser microsurgery. In the 1980s and 90s, just when science was determining and confirming that open partial laryngectomies, the conventional open partial laryngectomies, were yielding better control rates than radiation therapy in early laryngeal cancer, and also were offering a much shorter treatment rather than 6 weeks of treatment. Around that time, the laser, carbon dioxide laser, coupled to the operating microscope, arrived on the scene. And the advantages of transoral laser resection for early laryngeal cancers were enormous. One-day treatment, no hospitalization, no tracheostomy, no feeding tube, post-op course much smoother than any of the open partial laryngectomies. It was so good that today the conventional open partial laryngectomy, the horizontal partial laryngectomy or the vertical partial laryngectomy, is very infrequently performed, if not rarely. Transoral laser microsurgery has also taken a major bite off the radiation therapy, whichever institutions have that facility and expertise available in early laryngeal cancers. Next. The second development, which is very noteworthy, is the organ preservation plan in advanced cancer of the larynx. In T3 cancers of the larynx, it was seen that treatment with radiation therapy alone yielded a fairly high failure rate. More than 40% of the cases in T3 cancers failed to respond to the radiation therapy alone. Some of the failures could not be salvaged, and those that could be salvaged were salvaged with a total laryngectomy. In the ultimate analysis, when they saw the results of this radical radiotherapy followed by salvage surgery plan, you find that while some larynges were preserved, several lives were lost in that pursuit. It was at that time that institutions across the world recognized that that is not the plan to be followed, and total laryngectomy became the norm or the gold standard for T3 cancers of the larynx. But the surgeon was not willing to give up. The surgeon continued to find innovative ways of developing extended open partial laryngectomy procedures, like the supracricoid partial laryngectomy with cricohyoidopexy for a locally advanced glottic cancer, or the supraglottic partial laryngectomy with cricohyoidopexy for the locally advanced supraglottic cancer. And in more advanced cancers, the near total laryngectomy if it was a lateralized lesion. With all these voice conservation surgical procedures, the surgeon was able to avoid total laryngectomy in about 20% of cases, in cases who would have otherwise had to have a total laryngectomy. This was a great time for the head and neck surgery. Very exciting period. If you read the journals of the 80s and 90s, they are inundated with articles on voice conservation surgeries in advanced cancer of the larynx. And just while this euphoria existed, the medical oncologist came on the scene. The medical oncologist combined forces with the radiation oncologist and developed what was called the combined chemoradiation therapy. This combined chemoradiation therapy, following the RTOG trials and a lot of the EORTC trials also, showed that the organ can be preserved in almost 75% of the T3 cancer of the larynx, as against the surgical preservation of 20%. This then became the new norm for management of locally advanced laryngeal cancers, where the laryngeal framework was intact. This was the second major development that has happened in cancer of the larynx. The third development that we must acknowledge was the technological advance in radiation therapy with intensity modulated radiation therapy. And I will explain to you why this was important, like Rohit mentioned it also earlier. Cancers of the larynx where the anterior commissure is involved have always been a concern to the laryngologist or to the laryngeal oncologist. To the endoscopic surgeon, like Dr. Shaji pointed out, exposure of the anterior commissure is difficult, and transoral laser resection of anterior commissure lesions have much higher failure rate. If the anterior commissure lesions also tend to get understaged, very often a T4 lesion may be staged as a T2 lesion and labeled as an early cancer. But one of the things that was happening for very early cancers of larynx, which were extending to the anterior commissure, the radiation therapy beam, which is generally focused at the mid-cord level, by the time the radiotherapy dose reaches the anterior commissure, the dose became very ineffective. And anterior commissure involved early laryngeal cancers tended to fail to respond to radiation therapy. That is why in those days, very often, if an early cancer involved the anterior commissure, we used to offer them surgery as opposed to radiation therapy. We would do a frontolateral laryngectomy in those cases because radiotherapy was not able to give that dose. Now, with intensity modulated radiation therapy, not just the linear accelerator, but this particular thing, the intensity modulated radiation therapy, there is a uniform dose distribution to the anterior commissure also. So the misses are less. And the lesion can today, in good centers, be very effectively treated. T1 cancers can be effectively treated with radiation therapy, even if the lesion is reaching the anterior commissure. So with this background of the recent developments, or not so recent, but developments that are really positively impacting the outcomes in laryngeal cancer, I will try and take you through stage by stage the treatment options in laryngeal cancer and how your mind should function on selecting from the various options that you have and choosing the treatment that is right for the patient. Let us first start with the pre-malignant lesions or carcinoma in situ. One of the things that very often happens, patients present with hoarseness. On laryngoscopy, you see leukoplakia or a dysplastic lesion. You take a biopsy or you strip the cord. The report comes as carcinoma in situ. Very often, these patients are being referred to the radiation therapist for radiotherapy. And I want to emphasize here that radiotherapy is not the right treatment for carcinoma in situ. Something that is not invasive, it is best not radiated. The treatment for this is cord stripping. If the patch is very localized, excise the patch. If the leukoplakia is very diffuse, then do a cord stripping. It can be done with the laser, but it is preferably done with the cold steel to avoid thermal damage to the vocal cord. If the laser is used, it is better to use the Zeithel's technique, of injecting saline submucosally, lift the mucosa off the lamina propria, and then excise it with the laser. It protects it against thermal damage. Then the patient is counseled to quit smoking. Radiotherapy is best avoided. A regular follow-up is maintained. Next slide, please. There are ample meta-analytic studies that have been done, which have shown that the larynx preservation rates are much better if you have avoided radiation therapy. Give radiation therapy only to the very few and far between where the recurrences are coming very frequently or the follow-ups are not possible. Sometimes if the recurrences are coming very frequently, it is better to even do a chordectomy, including the lamina propria, rather than go on repeating the cord stripping, because that also ultimately damages the cord. Next slide, please. Let's come to the invasive cancers now. We'll talk about the T1 glottic cancer. T1 glottic cancer, the main treatment decision is influenced by what is the location of the tumor. These are tumors that are superficially invasive, the cords are freely mobile. If it is a mid-cord lesion, transoral laser resection is by far the best for these cases. Cure rates with both transoral laser resection and radiation therapy are both good. But with transoral laser resection, voice quality is reasonably good. If transoral laser resection fails, you can once again do a laser resection. If need be, an open partial laryngectomy can be done or radiation therapy can be given. But if radiation therapy fails, most of the times it will end up into a total laryngectomy. So if you really compare, both may give you equally good cure rates, but the larynx preservation rate is better if you pursued the path of transoral laser resection than whatever 15 or odd cases that you have failed in, you again salvage them with voice conservation procedures as against in radiation therapy when those cases will need a total laryngectomy. If the lesion is involving the anterior commissure, and if it is strictly T1, if you see on suspension microlaryngoscopy and you see that the whole lesion is within your field, and if the exposure is good, if there is no extension to the supraglottis or the subglottis, once again, transoral laser resection is safe in those cases. However, transoral laser resection, when it disturbs the anterior commissure, the voice quality takes a beating. And that is why for anterior commissure early cancers, radiotherapy is the first option if the patient's demand on voice quality is high. And most patients have high demand on voice quality. You can't say that only singers and television interviewers need good quality of voice. So radiotherapy becomes the first option, and transoral laser microsurgery becomes the second option. Below the dotted line and far away, you see that open partial laryngectomy is still an option. It is not totally out. It is not a footnote in surgery. There is a place for open partial laryngectomy in cases where, if you have a verrucous carcinoma, if you have a very young patient, if you have a patient who has had previous radiotherapy where you can't now give radiotherapy, or if you have a non-squamous cancer, like you very often see a neuroendocrine tumor nowadays, once in a while you see neuroendocrine tumor, these are cases where surgery is the main option. Radiotherapy is not the option. If in these cases you find that transoral laser microsurgery is not feasible because of inadequate exposure, the fundamental requirement for transoral laser microsurgery is a good exposure. Light travels in a straight line. If your exposure is not good, you must not embark on transoral laser microsurgery. Just abandon it. And if that patient cannot be given radiation therapy, then open partial laryngectomy has a place in these cases. Next slide, please. T2 glottic cancers are a little more complex and they need a little more explanation. In T2 glottic cancers, where the cancer is glottic and extends into the supraglottis or the subglottis, or it may have some impairment in the cord mobility. Here, the factors that really influence treatment decision is, one, of course, is the expertise available, facilities available, physician's preference. But really, if everything is available, the factors that influence decision-making is, what is the bulk of the lesion? Where is it located? Is it into the mid-cord region? Or is it at the anterior commissural lesion? And is there impairment of cord mobility? And if you have a non-bulky lesion in the mid-cord region, it will do well with radiation therapy. It will do well with transoral laser microsurgery, though the voice quality after transoral laser surgery for a glottosupraglottic lesion will not be very good. Voice quality with successful radiation therapy will be better. But both are more or less equal. Your first option will be radiation therapy. If the lesion is bulky, and if it is into the anterior commissure region, then radiation therapy alone is unlikely to work, and transoral laser microsurgery is technically very demanding for a bulky T2 lesion in the anterior commissure region. Very few people do this surgery. In order to reach that anterior commissure lesion, the surgeon has to resect a lot of the supraglottis, including a hemiepiglottectomy, to be able to then reach the lesion of the anterior commissure glottic lesion and then resect it. Failure rates are high. Sometimes you may have to abandon discover that it is not really T2 and it is more than that. And the quality of voice is not good. Most people are not adept at doing that kind of transoral laser surgery unless you are regularly doing it and practicing and believe in it. Instead, the open partial laryngectomy is a safer option where it will resect a T2 anterior commissural lesion with a supracricoid partial laryngectomy and cricohyoidoepiglottopexy. The cure rates are upwards of 90-95%. But this is a treatment that can only be offered to the very healthy, like Rohit mentioned. His pulmonary functions are excellent. He is a fighter and he will be able to take it. A lot of our elderly patients will not be able to take that treatment. And for them, chemoradiation is the best option for a T2 glottic cancer, in bulky T2 glottic cancer in the anterior commissure region. And one should not feel apologetic about using this multimodality treatment of chemo plus radiation in an otherwise T2 cancer. Because if you really see Arlene Forestier's RTOG trial, where they recommended concurrent chemoradiation for advanced laryngeal cancer, not all patients in that series are T3 cancers. A sizable number in that series are T2 cancers, which were otherwise going to have a total laryngectomy. So to chemorad a T2 bulky cancer in the region of the anterior commissure is perfectly in order, and one should not feel apologetic about doing that. Next slide, please. What about transoral laser microsurgery for supraglottic cancer? This has not been very well accepted. The main concerns in the minds of people who don't accept it is that supraglottic cancers have a tendency or have a propensity to have neck node metastasis, and laser resection will not address the lymph nodes. My reply to them is that just as you do an intraoral partial glossectomy and then address the neck nodes, you can do a transoral laser resection of the supraglottic cancer and address the neck nodes, either by the wait and watch policy for N0 neck or by the elective neck dissection for the N0 neck, or the definitive neck dissection for a palpable neck node. Palpable neck node with an early supraglottic cancer does not preclude the possibility of doing transoral laser resection. Transoral laser resection of supraglottic cancer is really fascinating. It is technically more demanding. Instrumentation has to be very good, but it is very satisfying. And there are a number of studies that have shown very good larynx preservation rates in transoral laser resection for supraglottic cancer. Your case selection has to be very good. It should be a marginal zone cancer, easily accessible. Epiglottectomy, resection of the epiglottic fold, resection of the upper reaches of the medial wall of the piriform. These can be done extremely well with the transoral laser resection. And if after that the patient needs radiation therapy for the neck nodes, the larynx should be shielded. The one thing that we must not do in laser resection is try to debulk and then hope that I will give the debulked lesion to the radiotherapist to radiate. No radiotherapist is happy radiating a raw area. And if that patient succeeds, the credit must go to the radiotherapist, not to you for having debulked it. When you do a microlaryngoscopy for supraglottic cancer, you make a good assessment and see whether I can resect it completely. If you get that assessment, cases with freely mobile vocal cords and arytenoids, and you can resect it, then only embark on resection. One of the advantages of transoral laser microsurgery for supraglottic cancers is, in the slide that you see to your left, in the slide that you see to your left, the lesion is overlying the arytenoid, and even bigger lesions than this. You can resect this lesion, lift it off, and keep resecting it in the submucosa. Your arytenoid will be preserved. In the days when we did a supraglottic partial laryngectomy for a growth that was overlying the arytenoid, the arytenoid had to go. But under the magnification of the operating microscope, when you resect these exophatic lesions, your arytenoid can be preserved, and that's a very big help in the post-op recovery. To provide that posterior glottic bulk, the aspiration is less and the voice quality is good. So this is my view for transoral laser resection for supraglottic cancer, and those who have the facility can definitely pursue, but have very good case selection and always want to do those who do not believe in transoral laser resection for supraglottic cancers will see that there are times when you have a post-radiation recurrence of an epiglottic lesion. If that larynx is not edematous and that recurrence is localized, you can resect it transorally with the laser. Otherwise, you are stuck with either doing a supraglottic partial laryngectomy with much greater morbidity or a total laryngectomy. At times you will have, like the slide on your left, is a neuroendocrine tumor. You have a non-squamous cancer in the glottis of the supraglottis. You can't treat them with radiation therapy. These have to be resected transorally with the laser. So there are situations where if you start doing your transoral laser microsurgery for squamous cancers, you will come across situations where you will really find that experience useful in dealing with post-radiation failures or non-squamous cancers of the supraglottis. Next slide, please. Then we have the T3 cancers of the larynx, and I think that we have discussed a lot on this thing. In T3 cancer of the larynx, there are two things that the student must see. You see this slide on the left, which is showing a fixed cord and freely mobile arytenoid. And you see the slide on your right, which is a completely fixed hemilarynx. Both are T3, but both are very important to distinguish if ever you have to consider doing surgery in these cases. In the slide to your right, where the hemilarynx is fixed, you cannot do a supracricoid partial laryngectomy because that arytenoid is fixed. All supracricoid laryngectomies have to be supracricoid. If the arytenoid is fixed, that means the cricoarytenoid joint is fixed, that means the cricoid cannot be preserved. There is no partial laryngectomy that can resect the cricoid. Cricoid is the lower limit, the upper border of the cricoid is the lower limit of your partial laryngectomy. So if you have a hemilarynx fix, you can never do a supracricoid laryngectomy. If your arytenoid is freely mobile, but you have to resect it because the lesion is coming close to the arytenoid, you can resect it. You can resect one arytenoid in a supracricoid partial laryngectomy, but not an arytenoid that has become fixed to the cricoid. Then you are cutting corners and your margins will be involved. But if mucosally the lesion is coming close to the arytenoid and you have to resect it, but it is a mobile arytenoid, it is not fixed to the cricoid, you can do that partial procedure of supracricoid partial laryngectomy. So I thought it was important for you to see this distinction. The second thing that I wanted to tell you, and I think that we missed bringing out that point when we were talking to, next slide please, when we were tackling Dr. Kannau, was that total laryngectomy is an option in T3 laryngeal cancer. If you have an 80-year-old doddering old gentleman, he cannot stand concurrent chemoradiation. He cannot stand any of the partial laryngectomy procedures. And total laryngectomy is an option in T3 cancer of the larynx also. Please remember that. Next slide, please. And if you have after chemoradiation, chemoradiation is the mainstay of treatment in T3 cancers of the larynx. If after radiation you have post-radiation edema, and if you suspect that there is cancer, sometimes you are in a fix. You do PET scan and you see that there is metabolic activity. You do a direct laryngoscopy, you do not see any mucosal lesion. You cannot plunge a biopsy forceps into that mucosa to get to the deeper tissue because you will initiate cartilage necrosis by doing that. In these cases, it is best to maintain a very close follow-up. You cannot sacrifice a larynx without a biopsy unless it is a useless larynx. If it has started causing obstruction to breathing, if it has started causing aspiration, then and only then are you justified in doing a total laryngectomy in a post-chemoradiation case where you strongly suspect that there is cancer deeper, and all of the maneuvers that Rohit also mentioned of a core biopsy, Rohit, you mentioned? Maybe. It is best not to do a total laryngectomy unless you have a positive biopsy. And finally, we have the T4 cancer of the larynx, where we have only, the main option is total laryngectomy. Sorry, this is the only stage where total laryngectomy continues to remain the gold standard of treatment, followed by adjuvant treatment with radiation therapy. And if the margins are closed or if the lymph nodes that are involved are showing perinodal extension of disease, then adjuvant chemoradiation. So if I may summarize, For an in situ cancer, for a T1, for an in situ cancer, a local excision or cord stripping, avoid radiation therapy, quit smoking. For a T1 cancer, mid-cord, transoral laser resection is the first option, radiation is the second option. Mind you, radiation is the most widely used modality for T1 glottic cancers and even T2. But still, if you have to really discuss in detail, if you have all facilities available, then transoral laser resection is superior in a mid-cord cancer. If it is at the anterior commissure, then radiation therapy with intensity modulated radiation therapy with good quality radiation is an advantage, because laser resection will disturb the anterior commissure and voice quality will not be good. It becomes a second choice. Open partial laryngectomy does have a place, but only in those cases where surgery is a must, and yet transoral laser surgery cannot be done because the exposure is not good. The patient is not able to extend his neck. The patient has submucous fibrosis. The dental arch is not conducive to getting a good microlaryngoscopy exposure. In T2 glottic cancers, the bulk of the lesion, the location of the lesion, and whether or not there is impaired cord mobility influences the treatment decision. For small lesions in the mid-cord region, transoral laser resection and radiation therapy are both good options. For bulkier lesions located in the anterior commissure, some impairment in the cord mobility, it is best to go for either chemoradiation or in young, strapping, healthy individuals, a supracricoid partial laryngectomy. Transoral laser resection is a technically very demanding procedure in those cases, and they're best avoided. T3 cancers, gold standard is total laryngectomy, but there are these other options. In elderly, morbid person, total laryngectomy may be the best option. And in T4, a total laryngectomy is the mainstay of treatment, followed by adjuvant treatment. Thank you.
Thank you so much, sir, for that wonderful talk. This brings us to the last small segment, which is Q&A with the experts. And because we discussed so much throughout the case discussion and the expert talk, I have just 3 questions from this chat on the YouTube. So I'm addressing these questions to particular examiners. However, the other examiners are more than welcome to also contribute. First question to Dr. Shaji Thomas, sir. Sir, any practical tips for the residents while performing emergency tracheostomy? You're muted, sir.
When you're doing emergency tracheostomy for a case of carcinoma larynx, you have to be planned properly. The incision has to be planned properly, anticipating a future laryngectomy procedure and a future end tracheostomy. So you have to plan so that you try to do a high tracheostomy as far as possible. And the incision should be planned such that a future laryngectomy can be, this incision can be incorporated in a future laryngectomy. These are the 2 essential things you have to remember when you plan an emergency tracheostomy for acute airway obstruction for a carcinoma larynx.
Any input from Dr. Rohit and Dr. Sultan?
You must know that if you're doing an emergency tracheostomy for cancer of the larynx, then you know that there is no other option for this man other than total laryngectomy. So doing a high tracheostomy, like Dr. Saji Thomas has mentioned, is the right thing to do. In a normal tracheostomy, you don't go close to the cricoid cartilage. But here, you know that he has a cancer of the larynx, and in an emergency you're doing, there's not too much planning to be done. You can do a high tracheostomy so that later on, and then take up for surgery early. Otherwise, there's a lot of inflammation around the tracheostome, and doing a definitive laryngectomy becomes very messy in a patient who has had tracheostomy for a very long time.
Our next question is to Dr. Rohit. Sir, we discussed a lot about the indications for PET-CT and when not to do it as well. So could you summarize your indications today for PET-CT?
We normally do PET-CT whenever you are suspecting a metastasis to the lungs. Second, when in a post-radiated patient where you are suspecting on your endoscopy that there is a recurrence and your biopsy turns out to be a negative for malignancy, you do PET-CT to see the uptake. If the uptake is there, and if you do an MR diffusion studies which shows that it is not necrosis or maybe presence of disease, then yes, we normally prefer to do MR first, followed by PET. So if MR is inconclusive, then we do PET-CT. And if there is an uptake, then definitely that helps us in taking the biopsies accordingly.
Shaji sir, you would agree with that, or you have any other indications that you follow, sir?
See, when you have endoscopy, there is an edema, which we are unable to differentiate whether it's post-radiation or a submucosal disease. So, and the patient is symptomatic. And the imaging, the conventional axial imaging does not differentiate. Then there is a role for a PET scan.
Stan Pradhan sir, any final comment on the PET-CT?
Yeah, I agree with Saji. I don't do MR for larynx. But as Saji mentioned, that if there is a clinical suspicion and there is post-radiation, whether there is post-radiation edema or whether there is submucous disease there, I prefer to do the PET scan. I don't really rely on the MRI very much.
Right. Final question for the day to Dr. Sultan Pradhan sir. Sir, any scenarios where a neoadjuvant chemotherapy would be preferred today?
So let me tell you that the RTOG study has shown very clearly that concurrent chemoradiation is good enough, and giving neoadjuvant chemotherapy is a waste of resources. In some way, they are just criticizing the EURTC study, which emphasizes a lot on neoadjuvant chemotherapy. But that one is more for hypopharyngeal cancers. But in laryngeal cancer also, I feel that there is a place for neoadjuvant chemotherapy. One thing that chemotherapy has shown is that those who respond well to chemotherapy are likely to respond to radiation therapy. So for a triage, it is a good modality to give, treatment modality to give. If I have a patient who is eminently resectable with a voice-conserving surgical procedure, if I have a patient who I know I can do a good supracricoid partial laryngectomy, then I fear straight away pushing him off into chemoradiation. I prefer successful chemoradiation to a successful supracricoid partial laryngectomy. I prefer, because as Kanna very rightly pointed out, the voice is very harsh after supracortical partial laryngectomy. So I would prefer to have success with chemoradiation, but I fear that if I send him for chemoradiation, and if he fails, and I think the failure chance is 25%, which is not low, then he will have a total laryngectomy. In such a case, I would prefer to give him neoadjuvant chemotherapy. And if I find that it is really melting away, I will just spare him surgery and send him for chemoradiation. If I find that it is not changing, I will take him up for a supracorticoid partial laryngectomy. Same for near total laryngectomy. If I find it is a clear-cut case for near total laryngectomy, very well lateralized lesion, opposite chord fully normal, interarytenoid fully normal, post-cricoid, post-retroarytenoid very supple. Clear-cut case of near total laryngectomy. But still, near total laryngectomy means a permanent tracheostomy. He will have a lung-powered speech, but he will have his nasal respiration is sacrificed. So I would rather succeed with chemoradiation than with near total laryngectomy. But I do not want to miss that opportunity. And that is why I will give neoadjuvant chemotherapy. I want to see that it is responding to neoadjuvant chemotherapy. Then I will spare him surgery and send him for chemoradiation. Fortunately, majority of the patients respond and they go for chemoradiation. And I do not do near total laryngectomies often. I do not do supracorticoid laryngectomies often. I do it very rarely. But in these cases, I do give neoadjuvant chemotherapy for triage. I hope I've answered the question. Have I?
Yes, sir. A very nuanced answer. Shaji Thomas, sir, and Dr. Rohit Nair, sir. Any input from your side, sir?
With the neoadjuvant chemotherapy, with such a strong regime, particularly in Indian patients, majority of these patients cannot withstand CTRT after neoadjuvant chemo. So if you're giving neoadjuvant chemotherapy, you'd end up giving them radiation. So that's the reason why we are offering chemoradiation for these patients straight away. Because tolerating neoadjuvant chemo and RT is very difficult for our patients. Majority of the patients, there are been mortalities after CTRT, after neoadjuvant chemotherapies. So if you are giving, then give CTRT rather than giving neoadjuvant chemo and CTRT. So if you are giving chemotherapy, only justifiable if you are going to offer them a laryngeal preservation surgeries, which Dr. Pradhan said is inferior. So if that's the reason why I don't agree with neoadjuvant chemotherapy for laryngeal cancers.
Shaji Thomas, sir.
There are only limited role for neoadjuvant chemotherapy in as far as laryngeal cancers are concerned. Just like Pradhan sir told, only those specific situations. Mainly the NSAT plays role in the hypopharyngeal cancers.
So that's all from my side. I would sincerely like to thank all the three examiners for so patiently and in detail answering these questions. I invite Dr. Sharad Desai sir to please give his remarks.
Thank you, Srijan. Actually, it was a great session. So it was a wonderful session today, and it was quite an elaborative session of the whole of the laryngeal cancers. Before I thank everyone, let me tell you a small story. It's a story which occurred 24 years ago. It was the same month, September 1997. I had failed in my first MCH examination. I was taking the examination for the second time. I was very much hurt and angry for failing. I was very much depressed also because I had nowhere to go and no one to for support. I basically came from an agricultural family and was very much stressed up. But then the case was cancer of the parotid. The examiner in front of me was very affable, very supportive, and he took me along. The external examiner, and he passed me. This was in Gujarat Cancer Institute. The external examiner who passed me was Dr. Sultan Pradhan sir. I still remember him, and I'm really indebted to him. Later on, and I started searching for a job. In those days, surgical oncology was not a famous super specialty. And I was searching for jobs all over. People were not giving me jobs. I landed up in this small place called Mirrors. I did not know this language. I did not know anybody here. But still, there was a new institute, and the institute was supported by Dr. Sultan Pradhan sir and Dr. Praful Desai sir. They used to keep on coming and visiting this institute in the initial period. They put their name behind this institute, and the institute got a great boost because of them, and it started. Then I took over. I started my career. Today, the institute has also grown. I left the institute, but today I have also grown. And I personally, again, take this opportunity to thank Dr. Sultan Pradhan sir for my initial days in surgical oncology. So thank you, sir. Today's expert class, your expert lecture was a class which took us through the fundamentals of laryngeal cancer. Wonderful lecture, sir. It reviewed us the whole basics of laryngeal cancer. Thank you, sir. And Dr. Rohit and Dr. Shaji, it is a real, not a small task to stand beside Dr. Pradhan, a person, Dr. Pradhan sir. He has such a big persona, his influence. You could still stand up to him. Wonderful effort from both of you. Thank you, both of you, for today's participating in today's masterclass. Thank you, Dr. Kanav. You have done well. And I think you should not worry about passing out failing. Like I know I am a repeater, and it doesn't really matter in life. And I wish you well, and I hope you clear your examination in the first attempt. Dr. Srijan and Dr. Rao, thank you for conducting all the masterclasses so well. I also take this opportunity to thank Dr. Arnab sir, Dr. Rudra Acharya, and all my IASO colleagues and all the members who have participated for making this masterclasses wonderfully successful. Thank you all. Stay safe, stay healthy, and wish you all a very happy Ganesh Chaturthi. See you soon.
Thank you. Thank you very much.
Thank you. Thanks a lot, sir.
Bye, Rohit. Bye,
Thank you, sir.
Thank you, sir.
Bye.
Thank you so much.
Shaji.
Thank you so much.
Thank you. Thank you very much.